Hello to one and all, to all our PhysioTV viewers. Today we have a very special session on Assessment Pre-Cardiac Rehabilitation, a Physiotherapist's Perspective by Dr. Aditi Ketkar Berry. Dr. Aditi is Assistant Professor in DES Brijlal Jindal College of Physiotherapy. She's a proud Manipal alumni and a gold medalist holder. So we welcome you, Aditi ma'am, and we hope that we have a wonderful informative session today. So over to you for Assessment Pre-Cardiac Rehabilitation, a Physiotherapist's Perspective.
Hello, one and all. Thank you, Suroshri, for such a wonderful introduction. Working with you is always special. So thank you very much for such a nice welcome. Okay, I'll just share my screen before we start.
Yes. Yes, the screen is
okay.
Yes.
Yeah, okay. Thank you. A warm welcome to all of you for today's talk on assessment before cardiac rehabilitation from a physiotherapist's perspective. I really hope that this session helps to add on to your knowledge about cardiac rehab. So when it comes to cardiac rehab, we as physios are referred patients usually post coronary artery bypass graft surgery or post angioplasty or post valvular replacement. Okay, we may also be referred patients who might have one or more of the modifiable cardiovascular disease risk factors like diabetes, hypertension, metabolic syndrome, and so on. So this is also included as a part of cardiac rehabilitation. Appropriate evaluation is very, very crucial before you start with any of the cardiac rehab programs. Also, it should not be like a one-time assessment program, but it is an ongoing process. So in this session, we would be discussing about evaluation or assessment from a physiotherapist's perspective. So like always, we start with the demographic data, which will include name, age, gender, date of admission, date of surgery, and date of examination. So date of examination should also specify the post-operative day that the evaluation is being conducted. Occupation domain, it should encompass all the details regarding the activity demands that the patient has at his work setup. So whether the patient is involved in, say, vigorous or moderate intensity, or is it more of sedentary sort of occupation, that needs to be specified. Also the duration that the patient is spending in doing that particular work needs to be specified. So these details will help in designing patient-specific cardiac rehab programs to further help him return to work. So approximate MET value of his work also needs to be specified. So that is important from occupation domain. So than just noting down the occupation, all these details as to what intensity and how long is he doing that work for that of that intensity, all these things need to be specified. Environmental history from our perspective should include all the details of his home and work setup, especially if you feel that they are going to contribute as environmental barriers, and that would further require some modifications. So all such details should be paid attention to and taken in detail. So post demographic data, next would be chief complaint. So most common chief complaints that are associated with these patients are pain, breathlessness, fatigue or tiredness, cough, difficulty in doing activities of daily living, and palpitations. So pain, these patients could be either chest pain or radiating pain or referred pain, specifically if you're looking at acute cardiac conditions, or it could also be sternotomy related pain, like post-op pain at the suture site, if you're talking about post-op patients. So this is followed by history of presenting illness. So history of presenting illness should basically amplify the chief complaint and describe how each symptom developed. So it should include all the details of the complaints raised by the patient. So it will start right from the onset or occurrence, and then the course of that particular symptom and progression. So we have already seen the commonmost complaints that these patients can come up with. So describing these complaints under all these attributes will ensure that we have a comprehensive idea about the complaint. So it should include location, quality, quantity or severity, timing. So timing should also include the onset of complaint, the duration of complaint, and the frequency of complaint. Setting, aggravating and relieving factors. and if there are any associated manifestations. So depending on now what complaint we are looking at, these attributes, like some of these attributes can be negated or can be added. So it will all depend on what complaints are we looking at. So these details will also give us some idea about the activities or the factors that would act or that can serve as limiting factors for our exercise program, especially when you talk about aggravating and relieving factors. So you need to identify these factors which can prove as limiting factors in our exercise program. So the most common scale that is used for dyspnea is the MMRC, that is Modified Medical Research Council. So it has 0 to 4 scoring, wherein 0 denotes breathlessness only while doing strenuous activities, and 4 denotes too breathless to leave the house or breathless even while dressing. In order to categorize the functional limitation of patients, especially the cardiac patients, New York Heart Association has given functional classification, which gives us an idea about if the patient is either comfortable at rest and what sort of, as in ordinary physical activity or less than ordinary physical activity, is causing fatigue, palpitation, and or dyspnea. So this classification comes in very handy when you are trying to grade the functional limitation of the patient. So in addition to this, whatever patients, the symptoms of the patients are, specific scales can be used to grade the severity of the problem. So this is then followed by the past medical history of diabetes, hypertension, ischemic heart disease, bronchial asthma, COPD, and so on. So it should also specify if the patient, along with the history that we usually take, it should also specify if the patient is on any regular medications for the same. If he's taking those medications regularly or is on intermittent treatment, that needs to be specified. Past surgical history, if any, that has to be mentioned. Now coming to family history, so along with the normal medical conditions that we routinely ask, right, that it is diabetes, hypertension, any history of coronary artery disease, along with this, it is very important that we take history of any death in the family due to sudden cardiac arrest or at a young age, which was because of the cardiac issues. So along with the normal routine family history that we take, these two things have to be included in the family history. So either sudden death in the family because of cardiac arrest or death at a young age owing to cardiac issues. That has to be specified. So in case of personal history, it will include sleep, appetite, bowel bladder habits, addictions in, and if any. If the patient has habit of smoking, it should be denoted in terms of pack years or any history of alcohol consumption. So sleep, basically, we need to know about the sleep patterns just to see if the chief complaint or if the problems that the patient is reporting is disturbing his sleep pattern. So this is followed by the drug history. So details of all the medications that the patient is on is to be noted, and we specifically need to know if there is any implication of the drugs that the patient is taking on the exercising capacity of the individual. So that is important. Than just the drugs, it is also important for us to know about its effects on the exercising capacity. Now, along with all these routine components of history that we take, we also need to pay specific attention on the physical activity history of the patient. So there are certain objective methods of measuring physical activity like the pedometer or accelerometers. There are also few subjective methods, for example, diaries or logs of physical activity, wherein these diaries or logs of physical activity are given to the patient and they need to maintain it daily, like how much of physical activity or what kind of physical activity did they do. But again, this is more or less of a subjective method. Objective methods are available like pedometers and all, so that those methods also can be used to analyze the physical activity history. So physical activity can also be, we can also know about the physical activity of a patient via self-reported questionnaires. So these two are very commonly used questionnaires, that is a Global Physical Activity Questionnaire and International Physical Activity Questionnaire, which will also give us some approximate idea about the individual's physical activity level. Now, these questionnaires include components that will look at physical activity, which is performed at work, also while commuting to and from places, and the recreational activities. So it has three subcomponents or three domains, especially the GPAC, and it will look at all these three components. So you have a comprehensive idea about the physical activity. So which is not just leisure related or recreational related. You will also come to know about his demands or the patient's physical activity at work or whatever activities are involved while commuting to and from places, as well as the leisure. So this is one of the positive points of these self-reported questions. So next important component is the metabolic equivalent or METs. So every activity that we do has a specific MET value, which will give us some idea about the energy expenditure. So it can also help us in grading physical activity in terms of energy expenditure or the intensity that is required for those activities. Now, the questionnaire that we just discussed will also give us an idea about or estimate the MET minutes of activities which are performed by the individual. So MET minutes, it is nothing but the MET value of a specific activity, which could be either moderate or vigorous in intensity. And that should be multiplied by the minutes that the individual is doing it for. Okay, so the MET value multiplied by the minutes for which the individual is engaged in that particular activity. So that will give you an idea about the MET minutes of that individual. Now, MET value for on an average, MET value for moderate intensity activities is roughly considered as 4, whereas for vigorous intensity activities, it is roughly calculated as 8. Okay, so if an individual is doing say in a moderate intensity activity, so for 30 minutes, suppose, so the MET minutes for that individual will be 30 into 4. Okay, so minutes, that is 30 into the MET value of that activity. So 30 into 4, that comes up to 120 MET minutes a day. Okay, so suppose this individual is performing that activity for say 4 days a week. So the MET minute value for that individual will be 120 into 4. Okay, so that comes up to 480 MET minutes per week. Okay, so you just have to multiply the number of days that the individual is doing that activity into the number of minutes that the individual is doing that activity into the MET value. Okay, so roughly it is considered as 4 for moderate and 8 for vigorous. So that this multiplication or this equation will give you an idea about the MET minute level of that individual for a week. So now let's take a look at some of the MET values for common physical activities and how are they classified. So this will give you an idea about the MET value. So if we take light category, so light category will have MET value of less than 3. So some of the examples are walking around slowly or say to the store or to office. Household and occupation categories can be making bed, washing dishes, ironing, preparing food, or desk job for that matter if it is occupation related. Leisure time activities could be arts and craft, playing cards. Most of the musical instruments also fall under the light activity criteria, billiards and darts. So all these sports will come under light intensity activities. Moderate intensity activity will have a MET range of 3 to 6 METs. Some of the examples are brisk walking, or household and occupation related will be heavy or deep cleaning, sweeping, mopping, carpentry, and so on. Leisure time or sports related activities would be swimming leisurely. So again, speed matters. So if you're going in for sprinting or anything of such intensity, it will fall under vigorous, but swimming leisurely or walking leisurely can still come under moderate. Badminton, table tennis, volleyball, so all these sports come under the moderate intensity. So if you have some idea about the approximate MET value range, it is easy to classify the patient's activities accordingly. Vigorous intensity activities will have MET range of more than 6. So in case of walking, it is jogging or running or hiking. Household and occupation related are heavy farming, carrying heavy loads, shoveling, digging ditches, and so on. Leisure time activity or sports will include tennis, singles, soccer, basketball, and so on. So if you have some rough approximate idea about all these three activities in all these three domains, whatever activities patients tell you, you can still classify it, whether it will be low intensity, moderate intensity, or vigorous intensity. Now let's take a look at this compendium of physical activity. So it will give you a detailed list of almost all the activities with their approximate MET value. Okay, so now just think of all the activities that you do throughout the day and analyze how much of time you actually spend in doing moderate to vigorous intensity activities and how much of time you spend in doing light or low intensity activities. Okay, so so I think most of us spend maximum amount of time in low or light intensity activities. If we are involved in active sports or an exercise of any form, we can still count up to moderate intensity activities. So see if this compendium can also help you to analyze the MET values of the activities which are reported to you by your patients. We'll share this link in the description box so you can make use of it. So all these histories we have discussed about past history, past medical history, surgical history, drug history, personal history, specifically from a cardiac rehab perspective. So after all these types of histories, it is followed by the investigations that were carried out. So stress tests are very, very important when you are talking about cardiac rehab. So stress test will give us an idea about the MET value that was achieved by the patient while he was performing the test. Ejection fraction from the echo report will also help us in the process of risk stratification as well as exercise prescription. So you will get some idea as to how much can you push and how slow you need to go in the exercise rehab program. So apart from that, routine x-rays that are done, angiography report, ECG reports, all these things need to be monitored. So observation will include built and nourishment of the patient, saturation, pallor, edema, if any, lymphadenopathy, icterus, clubbing. So grades of clubbing needs to be specified, and cyanosis. Along with that, you also need, especially in post-op patients, you need to note down the suture site, ICD in terms of location and patency, drains if present, supportive devices, central line, IV cannulas, artificial airways if any, ventilators and the oxygen therapy devices. Whenever you mention about ventilatory settings or oxygen therapy devices, the type of device, flow rate, FiO2, and in case of ventilator, mode, PEEP, and all these settings need to be specified. Breathing pattern of the patient and I/E ratio will also serve to be useful. So general examination again will include vitals, pulse evaluation. So along with the normal rate of pulse that we usually take, in these patients, you should also go in for other parameters like rhythm, volume, force of the pulse, tension, and also palpation of the peripheral pulses is necessary. Along with all these things, point of maximal impulse needs to be specified. Then routinely things that we do, chest expansion, chest symmetry, evaluation of any abnormal heart sounds or murmurs, presence of wheeze or other added sounds, normal MSK evaluation, which will include tightness, range of motion, muscle strength, and evaluation of other comorbidities like obesity, diabetes. So it might include sensory evaluation, balance evaluation, depending on the other impairments. So the most important component is assessment of functional capacity in these patients. So again, it can be assessed subjectively or objectively. Subjective methods include how many flight of steps can you climb or how many blocks or yards can you walk. But again, this is going to be subjective. So we try and rely more on the objective methods. So objective methods will include the maximal and the submaximal exercise tests. So the purpose of exercise testing could be either diagnostic or prognostic or therapeutic. So that is for exercise prescription. So coming to role of exercise testing, patients with cardiovascular disease should undergo symptom limited exercise testing before initiating cardiac rehab. So even if they cannot perform the maximal stress test, symptom limited testing is necessary before you start with the cardiac rehab, because it will help you to establish the baseline fitness level. Like if the candidate is really eligible to start up with the cardiac rehab, it will also help in determining the maximal heart rate of the patient, which can be used for precise intensity prescription. And it will also help to ascertain safety of exercise by evaluating the symptoms of the patients, or any ECG changes that would, as I said, contraindicate exercise training, and it should be repeated at least annually or as the patient condition warrants. Okay, so exercise testing, specifically symptom limited exercise testing, is very essential before we start off with the cardiac rehab. So next, coming to modes of testing, we are not going into depth of it. We'll just brush through some of the tests. So it could be divided into field tests. So 6-minute walk test is the most widely accepted field test, or it could be treadmill test. So for example, Bruce and modified Bruce protocols are the maximal stress protocols, or it could be mechanically brake cycle ergometer tests, or it could be the step test. So now, before opting for any of the testing modes, it is very, very essential that we go in for proper test of all the protocols and also check if there is any absolute or relative contraindications of that specific protocol. Okay, and again, before you perform any test, the termination criteria of that particular testing protocol needs to be verified. Okay, so once you're sure about all the relative absolute contraindications of that specific protocol or the termination criteria of that specific protocol, then you can go ahead with the exercise testing protocols. So there are some absolute contraindications to the process of exercise testing. So this will also hold true for the specific exercise testing, but these are the things that you have to rule out before you even think of initiating any exercise testing protocol. So absolute contraindications include acute myocardial infarction within 2 days, ongoing unstable angina, uncontrolled cardiac arrhythmia with hemodynamic compromise, active endocarditis, symptomatic severe aortic stenosis, acute pulmonary embolism, pulmonary infarction, or deep vein thrombosis, acute myocarditis or pericarditis, acute aortic dissection, physical disability. One second. Yeah, physical disability that precludes safe and adequate testing, and decompensated heart failure. So in presence of any of this contraindication, exercise testing is ruled out. So the relative contraindications to exercise testing are non-obstructive left main coronary artery stenosis or moderate to severe aortic stenosis with uncertain relation to symptoms, tachyarrhythmias with uncontrolled ventricular rates, hypertrophic obstructive cardiomyopathy, recent stroke or any history of transient ischemic attack, mental impairment with limited ability to cooperate. So it becomes tricky when the patient has mental impairments or difficulty in understanding, resting hypertension with systolic blood pressure or diastolic blood pressure of more than 200 by 110 mmHg, uncorrected conditions such as significant anemia, electrolyte imbalance, and hyperthyroidism. So these are still relative contraindications. So if it can be managed with discussion with cardiologists, you can still go ahead with the exercise testing, but it will require clearance from the treating cardiologist. So while performing these tests, symptoms like angina or claudication, dyspnea, and rate of perceived exertion need to be monitored very stringently. So this is a scale that can be used for angina, wherein the severity increases from 1 to 4. So 1 is mild or barely noticeable, 2 is moderate or bothersome, 3 is moderately severe or very uncomfortable, and 4 is most severe or intense pain ever experienced. So if the individual is grading it as 4, you might have to terminate the test. So this is a scale that can be used to determine the intensity of claudication. So severity again increases from 1 to 4, 1 being definite discomfort or pain, but it is only at initial or the modest levels. Grade 2 will have moderate discomfort or pain, from which patient's attention can still be diverted, for example, by having a word with him or with conversation. Grade 3, there will be intense pain from which the patient's attention cannot be diverted. And grade 4 is excruciating and unbearable pain, wherein again you might have to discontinue the test. So modified Borg dyspnea scale gives an idea about dyspnea or RP that the patient might be experiencing. So this is the modified scale, which will grade the dyspnea from 0 to 10. And you also have Borg scale, which is the original scale, which starts from 6 to 20. So this is again used to specify the rate of perceived exertion. So this grading of symptoms becomes very important in order to review the outcome of cardiac rehab program. Okay, so wherein you expect that these symptoms, if it will not, it might not disappear, but at least you expect that the intensity of these symptoms to downscale. So let's discuss briefly about the 6-minute walk test. So it is a self-paced test and it is going to assess the sub-maximal level of functional capacity. So it cannot replace Bruce protocol or modified Bruce protocol. So it assesses only sub-maximal level of functional capacity, wherein the patients get to choose their own pace. They are allowed to stop and rest during the test. If they have any major symptoms, they are allowed to stop and rest during the symptoms. Of course, the timer won't go off, but they can take break in between. Advantages of 6-minute walk test are: it is easy to administer, it is better tolerated, it is more reflective of ADLs than any other walk test, because most of the ADLs that we perform are at the sub-maximal level of exertion. So it is comparatively better tolerated by patients than the maximal tests. So it also helps to evaluate global and integrated response of all the systems which are usually involved during exercise. So not just testing, whenever we are giving them exercise programs, all the systems that will come into picture are getting tested over here. So we have the pulmonary and the cardiovascular systems, systemic circulation, peripheral circulation, blood, neuromuscular units, and the muscle metabolism. Now, since we have discussed today's lecture, we are going to focus more on assessment. But since we have discussed briefly about some of the parameters of exercise testing already, let's take a look at how can the results from whatever test we just discussed help us in prescribing intensity of our exercise program. So very briefly, we'll have a look at it. So as stated by Powell et al., some activity is better than none and more is better than some, okay, to a certain extent. So there is a very fine line between none and some and more and some, okay? So this gap can be minimized by an on-point prescription of intensity for our cardiac rehab programs. So important parameters that can be used for prescribing intensity are VO2 max, HR max. So HR max again can be measured measured by performing maximal stress test, and it can be used for prescribing the intensity. So intensity can be prescribed as percentage of HR max or VO2 max, or it can be in a range that can be obtained by using the Kavunan's formula. Okay, so either whatever HR max you get from the stress test report, you can either start with some percentage of HR max, or you can prescribe the exercise program in the heart rate reserve. So it will be HR max minus resting heart rate multiplied by the desired intensity. So depending on you're looking at low intensity or moderate intensity or high intensity, you can alter the percentages plus the resting heart rate. So I feel heart rate reserve is a better method than percentage of HR max, because you still have a range, proper range wherein you can make the patient exercise. So this formula again should be used only if you have HR max, which is derived from the maximal stress test, and not by using the equation of 220 minus age, because 220 minus age is taking into consideration only the age of the patient and none of the other factors which can actually affect the functional capacity or functional status of an individual, like gender or the occupation of the patient or presence of any comorbidities. All these things are not taken into consideration when you go by 220 minus age. So if you have HR max, which is derived from the exercise testing, maximal stress testing, they only then try and use the heart rate reserve formula. So activities can be prescribed by designating the target workload that achieves the training heart rate after performance of 3 to 6 minutes at that particular workload. So once you start exercising, you need to monitor or you need to alter the workload that you're giving so that the desired heart rate range is achieved, and that particular thing will be called as steady state. So that can be done by altering the watts on an ergometer or speed and gradient on the treadmill, or in terms of meds. So our basic idea is patient should be spending good amount of time, that is at least 20 to 25 minutes in the target heart range that we have obtained from the Kamunan's formula. So now let's see at use of 6-minute walk test or the data obtained from 6-minute walk test. How can that be used for exercise prescription? So the 6-minute walk distance that we have obtained by performing a 6-minute walk test, we need to calculate the speed in kilometers per hour. So we have the distance and we have the time, so we can calculate speed by using the formula 6-minute walk test distance in meters. So this is what you will get after performing a 6-minute walk test. So into 10 multiplied by 1000. So that will give you speed in kilometers per hour. So now training can be started at a specific percentage, say suppose 50 to 60% of this speed, and then it can be gradually progressed. So this has an advantage that it will be precise as compared to generalized treadmill walking program. So again, because it is derived from a 6-minute walk test report, we will have specific details of that patient or specific capacity of that patient. So we can prescribe exercise program or we can prescribe the treadmill speed depending on that specific distance. So for example, a person has completed 340 meters in 6-minute walk test. Okay. So his speed would be 340 into 10 upon 1000. So that comes to 3.4 kilometers per hour. So training can be started at some appropriate percentage of this particular speed, because then it will be specific to that patient. So in case if testing has not been performed at all, then exercise prescription, the intensity prescription will have to be more conservative. So you can rely on the patient's rating of perceived exertion along with signs and symptoms to provide some upper limits for your activity. So you will have box scale, so modified or the original box scale can be used for exercise prescription. But the 6 to 20 scale is a better way than 0 to 10, because specific categories like say 6 or 13 or 14 and so on will roughly correspond to the heart rate that is achieved at that particular stage. So suppose a person grades his rate of perceived exertion to be around 11 when he's doing an exercise program. So his heart rate roughly can correspond to 11 into 10, that is 110. Okay, so this can be considered as an indirect method of intensity prescription. Okay, so indirect, again, it will not be as specific as HR max or Kamunan's formula, but then using vague terms like brisk walking and all, you can still go in for RP prescription, or you can use the RP scale for intensity prescription. So the initial intensity can be around 12 to 13 on the scale of 6 to 20, and then you can progress accordingly. So when the individual grades his RPE to be less than 12, that is considered as light, and approximate percentage of maximal capacity then is less than 40. So this is again approximate estimation. When the individual grades it as 12 to 13 or somewhat hard on the scale, it is approximately 40 to 60% of the maximal capacity. If the individual is going to grade it as 14 to 16, which is hard or heavy, then it will correspond to around 60 to 85% of the maximal capacity. So RPE can be used as an indirect method of intensity prescription. As I said, if you have HR max, you will always rely on the Kamunan's formula. But if you don't have any, or you want to give home program, then RP can also serve to be an important parameter. So this is a relatively very simple way of monitoring intensity, wherein the individual should be able to talk to you comfortably while exercising without being too distant. So suppose you are giving home program to a patient who cannot make it for supervised sessions in phase 2 or phase 3, then you can go in for talk test, wherein you need to explain the patient that whenever you are exercising, the intensity should be such, or the difficulty level should be such that you are able to converse comfortably. So again, the most reliable parameters will be VO2 max, HR max. Then if those factors are not there, then RP and talk test is of the least significance. So the last part of assessment is going to be restratification. So it is basically a part of it is basically a process of assigning participants into categories of low, moderate, or high risk. It is very essential to make appropriate recommendations for medical examination or exercise testing and training programs. So again, before you go ahead with the cardiac rehab programs, it is necessary to stratify the patient for his risk. So ACSM risk stratification categorize the patients or categorize CVDs in terms of diseases, signs and symptoms, and cardiovascular disease risk factors. So depending on the presence or absence of these diseases, signs and symptoms or risk factors, the grading is done. So the diseases that are looked for are cardiac, peripheral vascular diseases, cerebrovascular disease, COPD. In case of pulmonary, it is COPD, asthma, interstitial lung disease, cystic fibrosis. And when we look at metabolic, the diseases included here are diabetes, thyroid disorders, renal or liver diseases. So these are the diseases that are included in the ACSM risk stratification. So you have cardiac, you have pulmonary, and you have metabolic. So the signs and symptoms that are usually the signs and symptoms included in this stratification are pain and discomfort or anginal equivalent, shortness of breath, which could be either at rest or mild exertion, history of dizziness or syncope, orthopnea or paroxysmal nocturnal dyspnea, ankle edema, palpitations or tachycardia, intermittent claudication, or any history of known heart murmur, unusual fatigue, or shortness of breath with usual activity. So these are the signs and symptoms that are asked for risk stratification process. Risk factor included in this ACSM stratification is positive. You have positive risk factors and negative risk factors. So depending on the patient's reports, if you have a negative factor, you have to subtract one from the positive risk factor. So in case of age, it is if it is more than 45 for males and more than 55 for females, it is considered as a positive risk factor. Any family history of cardiac diseases, cigarette smoking, sedentary lifestyle, obesity, hypertension, dyslipidemia, and pre-diabetic range. So all these are positive risk factor. Negative risk factor includes serum HDL cholesterol, that is the good cholesterol of more than 60 mg per dl. So if the patient has this negative risk factor, you can subtract one of the positive risk factors. So in order to label the individual under low risk, the person should be either asymptomatic men and women or who have less than one CVD risk factor. If this is the case, so the person is free of symptoms and has only less than one CVD risk factor. So then he'll fall under the low risk category. If the individual is asymptomatic and has more than or equal to two cardiovascular disease risk factors, then the individual is graded under the moderate risk. If individuals who have known cardiovascular or pulmonary or metabolic diseases or one or more signs and symptoms, the patient is categorized under high risk. So we have seen the metabolic diseases, we have seen the cardiovascular conditions and the pulmonary conditions. So if there's any of these conditions or the signs and symptoms that we just saw, any of this is present, the individual is directly graded under high risk. So once you stratify the risk, you need to know the recommendations for that particular category. So if the person is falling under low risk, medical examination and exercise testing before exercise training is not necessary. Physician supervision is not needed if you want to conduct a submaximal or maximal stress testing. So this holds true for the low risk category. In case of moderate risk, medical examination or exercise testing before training is not necessary, provided you're going to go in for a moderate intensity program. If you're going to go for a vigorous intensity program, you will require medical examination and exercise testing. So it is recommended in case of vigorous intensity program. Physician supervision is needed for maximal stress testing. So submaximal stress testing can still be conducted by us without physician supervision. But if you are to perform a maximal stress test, physician supervision is recommended. If the individual is falling under high risk, medical examination and exercise testing is necessary before training. So we need to have exercise test report and also clearance from treating cardiologist that the patient is fit to exercise. So recommended level, it is recommended for even moderate and vigorous intensity exercise program. So we will have exercise programs of moderate intensity. So it is always better to get clearance from cardiologist before you're going to treat a high risk patient for cardiac rehab. Physician supervision is again needed for submaximal as well as maximal stress testing protocols. Now, risk stratification criteria is for cardiac patients is also given by the AACVPR, that is American Association of Cardiovascular and Pulmonary Rehabilitation. So for an individual to be graded under lowest risk category, all the characteristics that we'll be discussing shortly have to be present. Only then the individual can be categorized as having low risk. If the individual is to be categorized as having moderate risk, any one or combination of the findings has to be there. Whereas if an individual is to be graded under high risk, any one or combination of the findings that we'll be seeing shortly should be present. So for ease of understanding, I have just tried and compared it parallelly. Like we'll talk about the lowest risk and the highest risk together, then finishing all the low risk first and then coming to the high risk. So we are looking at the exercise testing and recovery findings. So you, in case of risk stratification, you have exercise testing findings and non-exercise findings. So we'll try and compare the exercise testing and recovery findings for lowest as well as the highest risk. So for lowest, it is going to be absence of complex ventricular dysrhythmias, absence of angina or other significant symptoms like dizziness, presence of normal hemodynamics, and functional capacity of the individual will be more than 7 minutes. So this functional capacity, you will get an estimate of this once the individual has undergone maximal stress test. If you have to grade the individual under highest risk, again, there will be presence of complex ventricular dysrhythmias, presence of angina or other significant symptoms like dizziness at low levels of exertion. Okay, so these patients will have less than 5 minutes during recovery, high level of silent ischemia during the test, that is ST depression of more than 2 millimeters from the baseline will be there, or presence of abnormal hemodynamics. Okay, so any of this feature is present, the individual will fall under high risk. Whereas for the individual to classify as in low risk, there should be presence of all these findings which are listed under the lowest risk. So this is just a comparison of the exercise testing findings. Next, talking about non-exercise findings. So in case of low risk, the individual's resting ejection fraction is more than 50%. The case is uncomplicated MI or revascularization procedure has been done. Absence of complicated dysrhythmias at rest, absence of congestive heart failure, absence of signs and symptoms of post-event or post-procedure ischemia, and there is absence of clinical depressions. Whereas for the high risk category, the ejection fraction, resting ejection fraction is less than 40. There is history of sudden cardiac arrest, complicated. So patient might be resuscitated post sudden cardiac arrest, but there is history of sudden cardiac arrest, complicated MI or revascularization procedure, complex dysrhythmias at rest. There is presence of congestive heart failure. There is presence of signs and symptoms of post-event or post-procedure ischemia. So post-operation, post-surgery, ECG will show some signs of ischemia, and there is presence of clinical depression. So again, for the individual to qualify for low risk, all of these factors have to be present. And even if a single factor from the high risk category is present, the individual will be classified under high risk. So once we have stratified into low and high risk, then it is easy to just compare about the moderate risk. So in case of moderate risk, there is presence of angina or other significant symptoms, but only at high levels of exertion. Okay, so more than 7 minutes. In high risk, we just saw with exertion of less than 5 minutes, also the patient has presence of angina. Whereas in case of moderate, there may be presence of angina or other significant symptoms, but only at high levels of exertion, that is more than 7 minutes. So there can be mild to moderate level of silent ischemia during exercise testing or recovery, but ST depression is less than 2 millimeters from the baseline, and functional capacity of the individual is less than 5 minutes. So this capacity, again, you will come to know after the stress testing is done. Non-exercise test findings is resting EF of 40 to 49% for moderate risk. So now once risk stratification is done, we also need to look at some of the outcome measures that should be used. So outcome measure is basically a measure of change which can be either favorable or adverse and in the actual or potential health status of a person. So outcome measures are necessary to establish if you have made any progress in the cardiac rehab program. So we need to establish the baseline data for adding objectivity to our assessment, for regular review of patient status, to alter or refine treatment depending on if there's any progress or deterioration in terms of outcome measures, and also to develop new interventions. So for dyspnea or functional limitations, we can use the MMRC or the New York Heart Association, that is NYHA grading of functional limitation. If it is RP, we can use the box scale or the modified box scale. As far as pain is concerned, we can use either NRS numeric rating scale or visual analog scale, or if the patient belongs to pediatric category or difficulty in understanding, we can go in for Wong-Baker scale. Barthel index is used to categorize their independence level for performing ADLs. So Barthel index needs to be taken. Psychological aspect also plays a very, very important role as far as the process of cardiac rehab is concerned. So analyzing their psychological component or assessing their psychological component is also important. For that, we can use hospital anxiety and depression scale, HADS, commonly called as. It is very useful in measuring anxiety and depression, which is very commonly seen in the hospitalized patients. Quality of life, again, it is the degree to which an individual is healthy, comfortable, and is able to participate or enjoy life events. So it is again a very multidimensional aspect, and which will include emotional, physical, material, as well as the social well-being of that individual, and which is again very, very subjective. So for quality of life, we can use either SF36 or SF12. SF36 again will give a more detailed or more comprehensive approach to this particular domain. So next is the Duke Activity Status Index, DASI, most commonly called as. So it helps to evaluate the functional capacity of patients with cardiovascular disease, such as coronary artery disease after myocardial infarction or heart failure. It can also be used to assess the effects of medical treatments and cardiac rehabilitation programs. So positive responses are summed up to get a total score, which ranges from 0 to 58.8. Higher score will indicate higher functional capacity and vice versa. So the added advantage of this scale is that it will also give you a rough estimate of VO2 level, peak VO2 level. So it is not achieved, so it is predicted peak VO2 level and also the approximate MET value. So this is the scale, and if you see at the end, you will get the total score, and you can predict the estimate the peak VO2 by using this score. Okay, so by the given equation, you will have some estimated peak VO2 measure, and with that you can again calculate. If you have the oxygen expenditure, you can again calculate the MET value for that patient. It will not be as reliable as the stress testing that can give you, but it can still be some approximate measure of the MET value. So just to summarize again, we have seen important aspects of history taking. I told you, like we do the routine screening, we need to focus more on the aspects that can either serve as barriers or even facilitators for our cardiac rehab program. So try and pick up on those points when you're taking history of these patients. The physical activity history is very, very essential. So you need to know the physical activity level which is required at work or what they are engaged in commuting to and from places, as well as their leisure related. So approximate MET value is again necessary. We then saw about some commonly used exercise stress tests. So the most common submaximal field test that is used is 6-minute walk test, and the maximal stress test are the Bruce protocol and the modified Bruce protocol. Then just to give you an overview, we have spoken about some of the components from exercise testing that can be used for appropriate or apt intensity prescription. Then we saw the process of risk stratification. So we have seen ACSM as well as AACVPR risk stratification. And then we saw about the outcome measures. So outcome measures that can be used for symptoms, that can be used for the psychological aspect, that can be used for functional independence, as well as the DASI. We have seen DASI as well as the psychological aspect and the quality of life. So I think that summarizes our assessment that we discussed about today. I hope it has solved some of your doubts, and I'll be more than happy if I could solve any of your doubts. So you can reach out to me for that. And I hope it has added on to your knowledge of cardiac rehabilitation. So my best wishes to all of you to carry out a safe cardiac rehabilitation program. Thank you.
Thank you so much, Dr. Aditi, for giving such a beautiful insight on physiotherapist's role on pre-cardiac rehabilitation. And it is so important to know that what a physiotherapy has to offer before planning for cardiac rehab as well as screening. So we thank you from PhysioTV and PhysioTV team. Thank you so much. And I'm sure that our students will learn a lot after listening to this session of yours. Thank you so much, Doctor.
Thank you so much. I really had a nice time. Thank you for inviting me. Thank you.